Introduce first Dr. Andrew Kerklaan, right here. Introduce Karen Hufnagl, right here. We got Janice Knox, and then we got Dr. David Knox. So we're going to start this now. There's a lot of questions, obviously, about CBD and where it's going and its future. So let's start with you, Dr. Kerklaan. I was just kind of wondering, right now, when people come to you, what kind of things are they looking for CBD to work on, health-wise?
Well, thank you for the question, and hello, everybody. Happy to be here. I flew in last night from Montreal, so my perspective is a little different because I've been in practice. I practiced in Europe for 5 years and then practiced in Canada for the last 15 years. And I am a chiropractor by profession, so I've always tended to see the person who may be looking for perhaps more of a, we'll call it a natural approach to health. So, one of the most common questions is that, sorry, that was the most common question relating to CBD, is really down to the definition. I find people are asking me, what is the difference between THC and CBD, and some of the confusion around CBD derived from hemp, CBD oil, full spectrum hemp oil, and they're trying to understand these different wordings. And part of it relates to some regulatory issues which may require some products to say hemp instead of saying flat out CBD. And then ultimately what I'm describing is that CBD is a molecule, so whether it's derived from cannabis or from hemp, it is CBD. So what they're really ultimately asking for is there a product that is as effective as it could be, perhaps with other molecules there, as opposed to purely taking a CBD isolate. So they're really, they may have heard that this full spectrum or hemp extract may offer more relief than pure CBD, or they may be concerned that other molecules, other things in there that they don't necessarily know are in there, and would they be better off to have a pure CBD concentrate. So that's one of the questions I face most often. And from a science background, it's pretty easy to explain that a molecule is a molecule. It doesn't really matter where you get it from. So ultimately, perhaps the potential for entourage and the entourage effect and the benefit of having other cannabinoids and terpenes in there, making a more complex response from the body as opposed to ingesting or topically applying just a CBD on its own. So that's one of the issues that I find comes up in clinic most often.
CBD has so many different applications, tinctures, topicals, capsules. What do you find most effective, and what do patients seem to want the most, or does it just depend on their ailment?
It does depend on their ailment. I find it depends on their age. And what I see, perhaps I'm a bit biased, I am in the topical space, but I generally find people there's a low barrier to applying a topical. So they're willing to try that. And I even see people who may be getting a topical for grandma or grandpa and simply saying, just try this. And they don't necessarily know what they're trying. But so it's generally seen, the topical scene as a low risk, low barrier to entry sort of product. And then as you go up through the range, then I think there's more questioning put into the ingestible stuff. So the oils, the edibles, the tinctures.
And finally, it's obviously something that senior citizens are getting turned on to, and millennials. What are you finding the age demographic in your practice? In practice, I saw kids all the way through to I think 93 was the oldest patient I had. But there's a statistic in Canada which some dispensaries, the average age entering into some dispensaries was 55. So I think there's a big push in the baby boomers towards health and wellness, and I do believe that's driving a lot of the interest in CBD and cannabinoid space in general. So I think the baby boomers very interested in longevity and very active lifestyles,
concerned about complex medication interactions and, wanting to remain active. So I think they see this as a great potential health opportunity, minimal risk, natural source. So I do believe the baby boomer is the main category there. I think the millennials, and younger just grew up with information at their disposal, just through their phone. So I think there's no stigma for them, and I think it's a much easier decision, so to speak. Whereas I think the older age groups are questioning and looking for more data, but very, very open and very keen on getting that information.
Thank you very much. Doctor, you've been working in hormone and thyroid area for most of your career. What piqued your interest about CBD, and what are you finding? How is it helping your patients?
So some of the interest was piqued from my personal experience and how it helped me, and then some of it also was there's such a huge connection between the body's stress response and how hormones respond, sex hormones, thyroid hormones, they all respond. And so given that CBD can help modulate that stress response, that ties into how well the thyroid hormones work, how well the sex hormones work. And so with that, I was able to use that to help some of the people who were not able to necessarily get the kind of outcomes that we would like if we're just strictly working on thyroid function or just strictly working on sex hormone balancing. And so by helping to modulate the stress response using CBD, then their body's own production of some of those hormones goes up, the balance in those hormones evens out, and they ultimately end up feeling a whole lot better than they would have if we weren't factoring that whole stress response in the mix, and CBD was really helpful for doing that.
So obviously you were using other medications in your practice before. Is this something that you're using to supplement, or are you weaning your patients off their prior medications? Or do you just do it case by case?
It is case by
Yeah.
case because, I mean, the approach I'm taking is functional medicine. So in that is I'm looking at everything collectively anyway and all together. And so for some people, yeah, we're able to actually taper them off of the medications that they're on. And for others, it's an adjunct. They do actually need support in multiple fronts simultaneously.
And then finally, you also work with a lot of athletes. Where do you see this going in terms of the NFL, the NHL, Major League Baseball, basketball? Are there any side effects? And what about the testing? Because that's a question I get a lot from my athlete friends.
Yeah. So the World Anti-Doping Agency removed CBD from the prohibited list starting in January of this year, but THC is still banned. And so one of the things for professional athletes, obviously in particular, but any athlete that's in any kind of a competitive space to pay attention to is whatever product that they're using, they want to make sure that they're getting a certificate of analysis from that manufacturer showing that it is THC free so that they're not inadvertently ending up with a positive test. And then in that testing space, there's some tests they're very general and they don't stratify out and differentiate which cannabinoids are present. This just, is a cannabinoid present, yes or no? So CBD in that situation would trip a positive test, but it doesn't specify, oh, it's CBD. Other tests will actually differentiate that out, and then you can tell, okay, well, this is just CBD in the system, and it's not a THC-based positive on that test.
And do you know of any of the major sports that are like using it right now? Doctors?
That are using tests? Or
are using CBD for their players?
So in the professional realm, I am not working with any professional
Got it.
athletes myself. I work with lots of other recreational athletes and very serious athletes, but not in the professional realm. So that's probably not an area that I could give a definitive answer on.
Got it.
Yeah.
Well, thank you.
Yeah.
Dr. Knox? Yes. You spent your career in anesthesiology,
That's correct.
saving lives. Kind of the same kind of question. How did you get turned on to CBD, and are you finding it replacing certain methods that you use?
Well, first off, let me tell you, I was an anesthesiologist for 30 plus years. I call it a legalized drug pusher, best of them all. But when I retired from anesthesia, I was invited to one of the cannabinoid clinics to write cards. And I had my preconceived notions of who those people were going to look like and was surprised because they weren't, drug-looking, seeking people. They were that 55 age group and above. Grandparents, retired doctors and lawyers and bankers. And they really were coming to get off opioids and the multiple pages of pharmaceutical drugs, looking for a better quality of life. And what was more important, they were looking for physicians who could tell them how to use that medication. And that wasn't me at that time. I went to school at UC Berkeley, never saw cannabis. So I couldn't tell them a thing about cannabis. But what it did, it was very humiliating, but also it stirred the scientist in me because I wanted to be that doctor who could answer those questions. So I went and studied and I read everything I could, including the congressional records for why cannabis was off the pharmacopoeia. And what I learned was just mind-boggling, because then I learned not only about the science of cannabis, but I also learned about that physiology called the endocannabinoid system. And the more I learned about that system, it boggles my mind that they can teach physiology anywhere without talking about this system that controls all physiology, from conception to death. That endocannabinoid system is adjusting and readjusting to keep your body at homeostasis. So every physiological system is working in harmony. And when that system is not in harmony, that's when we see disease processes. And so not only did I see that as a consumer, but as a healthcare provider, I felt cheated out of some knowledge, because even as an anesthesiologist, I could tell you that I could have used some component, in particular CBD, to help my patients both preoperatively and postoperatively. Talking about decreasing inflammation, I would have put patients on it a week before surgery to not only decrease inflammation, but to decrease post-op pain and their post-op need for opiates. So it really was mind-blowing to me. It made me angry, but at the same time stirred the scientist in me to learn more and more about it.
You're also really involved in the cannabinoid group.
Yes, I am.
Can you walk us through that?
Yeah.
It's very impressive.
Okay. My family and I, 2 daughters who are physicians, and my husband here, we all do what we call cannabinoid therapeutics. And what we do in our clinics, the American Cannabinoid Clinics, we apply the science of cannabis to that very complex physiology of the endocannabinoid system. So we call it cannabinology, the science of anything that has cannabinoid-like properties that we can apply to the study of the ECS, which we call endocannabinology. And once you understand how that system works, then we can better sort of figure out which cannabinoids work best for which diseases, including cancer. Because there was years and years before they thought that the cannabis worked sort of indiscriminately on cell membranes. But with the research and understanding the ECS, we now know that it targets certain receptors on cell membranes. So that understanding is pretty huge, and that's what we do in our clinics. We take an integrative approach to cannabinoid medicine, starting with everything about that patient. And our goal is, if they're on a lot of pharmaceuticals, to try to get them off as many pharmaceuticals as we can, but to try to target their cannabis therapy, so we're not just throwing cannabis at them. We're saying this cannabinoid is best for you. And there's plenty, like, for example, breast cancer, where CBD is the lead cannabinoid, because we know that receptors, the receptors that are upregulated in that disease process.
And finally, so you talked a lot about the receptors, and I know that opioids are a big thing. Talk about how CBD and opioids differ in working with pain on the receptors.
Okay, so
Yeah.
that's really interesting. CBD has a long list of benefits that it does, but they're all very powerful anti-inflammatories. But one of the things that I think a lot of pain clinics do not get is that because we do not have CB receptors in the brainstem or places where we have the respiratory center or the cardiac center, we don't get respiratory depression. So you get the opioids and cannabis working synergistically. So as we increase cannabinoid use, we can come down on the opiates. And that's because the cannabis product CBD also works to increase those endorphins in your body. So it stimulates those endorphin receptors to produce your own endorphins. So we can come down off the opiates this way and go up on the cannabinoids. And so they're working synergistically, not, to depress a patient, but synergistically to get a better outcome.
Thank you very much. Very informative. And Dr. Knox, you've been working in emergency medicine. I'm sure you've seen a lot of horrific things. How does CBD fit into what you do?
Yeah, I've been an emergency physician for 40 years, and I was cannabis ignorant, shall we say, for 35 years of that. And when we started, seeing more use of, cannabis in Oregon, of course, they've had a medical program for some time. We'd see patients in the ER, and they would maybe tell you, I'm on medical marijuana, and you kind of say, okay, so what? Let's go on to the problem you're here for. But the evolution is that it's becoming, I think, more prevalent, and people are much more willing to be more open with it. I think that it's also on the physician side too, understanding it more, knowing something more about it. They're much more willing to open up to you and, kind of tell you what they're using, and it's much more able to have a conversation with them. As far as the use of the cannabinoids in the emergency room, I would have to say it just doesn't really exist at this point. CBD is really more long-term therapy, therapeutic goals, and in the emergency room, we're always really focused on acute problems. What are we going to do today, and kind of set you up. But the fact is that it does give you a little more discussion point with the patient. For example, you see a lot of patients, they've got chronic pain issues. They're in the emergency room today because they've got an acute exacerbation of that pain. Yeah, we can give you a shot of morphine or whatever, and kind of alleviate that pain immediately. But then what do? You up your dose of opiates, or you add an anti-inflammatory or a muscle relaxant or a neuroleptic like gabapentin, all the usual pharmaceutical things. But really, I look at now I've got another tool that I know about, and we can discuss intelligently. You add CBD to it, it's going to be helpful. There's not a downside to it. So particularly with opiate use, as Dr. Janice said here, it makes it more effective. They're synergistic. You get better pain relief with a lower dose, and you don't develop the same tolerance, and you really avoid the potential for toxicity that the opioids pose, as we all know. So.
You guys were, I think, the second or third medical state, right? Was Washington before you or after you? Second, yeah. So you guys were blazing the trail, so to speak. Do you still get questions about, does CBD get you high? Is that something you hear a lot?
Yeah, there's still a lot of concern about, cannabinoids in general. Even though we are seeing more and more patients, it becomes more and more apparent, how many people are just using it. Are they using it optimally? That's the big question. So, particularly in our clinics, that's what we want to figure out. Okay, how can we give you optimal benefits and minimal side effects? So that's a little more complex than where we started, which was just writing an authorization. Yeah, go get your weed and have a good time. But there's more we know the science, the more we know we can be more specific and design a program that's really going to help. So. It's a matter that, people aren't too worried about CBD getting you high, but they're just worried about, other side effects, and then, of course, the legal question, whether, it's going to affect a drug test or that type of thing. So, so we can answer those questions a little more, but, it's still a little open-ended. I had a patient in a clinic a few weeks ago. He was using what he thought was a pure CBD product, for his chronic pain issues. He was getting great results. no side effects whatsoever. Little on-the-job injury, gets a drug test, and he's positive for THC, because, again, legal limit, 0.3% THC. It's a CBD legal product. You can use it, no effect, but you get a positive test. So, you know, so those are more the kind of questions that we ask. But again, you know, with patients presented in the emergency room, again, it's usually more of an acute problem. I'd say primarily pain problem, but, you know, we'll see cancer patients. Being able to really, you know, discuss a lot more about, you know, how you can use CBD and other cannabinoid products. An example, I had a guy had, you know, stage 4 lung cancer. He had pleuritic pain, you know, because it metastasized to the surface of his lungs. So it's like, you know, horror pleurisy. It was on high-dose opiates, couldn't get pain control. You know, now you can say, you know, add the cannabinoids, you know, and have a much more, you know, effective result. So.
And finally, so in like, what I asked earlier, application process, is it just depend on the patient's needs, or do you have a preference on, obviously topicals are more for pain and joint arthritis, tinctures, but like, do you have a preference with the guy who had the lung problem? Like, what did he do?
Yeah, well, you know, hopefully we got him on usually tinctures or where we start, you know, and just, you know, it's not a situation where you want to do a lot of inhalation, you know,
Right.
And all, and then it's, you know, it's a deep structure problem where the topicals don't really reach. But, you know, again, it depends on the medical problem, and you know, we kind of call it a layered approach, okay? If you got arthritic pain, you got even peripheral neuropathy, and I'm still astounded with that one, it's a nerve problem. People that get relief with topical products is astounding. You know, topical alone, that's all I need for that peripheral neuropathy that was, you know, making my feet, you know, feel crazy. You know, so that's a first layer. We like oils and tinctures. I kind of, you know, put them in the same. It's just, you know, the oils are often more concentrated. Tinctures have been a little more diluted, but take them sublingually, you know, rub them in the gum line, nasal septum, you know, those approaches. You know, I think the one way we prefer, because it's a little more measurable as far as the dose you're getting, so you can, you know, judge your response and make adjustments in how much they're using. Fairly quick in onset, but it lasts longer than inhalation. You know, a lot of problems, you know, from low back pain to cancers, pelvic problems, prostate. You know, suppositories are a great route. You know, get excellent absorption, and you know, true edibles, we like, they have a good role where you want a long-term effect, you know, the last 6 to 8 hours. The downside is they're very slow in onset, and again, because of first-pass metabolism in the liver, you got to be a little cautious about your THC dose, so you're not getting, you know, too intoxicated with them. Finally, the inhalation route, you know, we figure that, at least at this point, vaping is a little safer than smoking. Not that there's big risk, but either way can cause airway irritation with cough, even though we don't see the long-term, you know, COPD and cancers and stuff you do with tobacco, but it can still be an airway irritant. So we kind of just take that, you know, kind of series of approaches. It's still kind of a matter of titration, because everybody's endocannabinoid system is individual. We've got different tolerances, and you know, the mantra is, you know, you start low and you go slow, but you can just kind of titrate up to what that minimal effective dose is, where you're getting relief of your symptoms and hopefully avoiding those systemic side effects you don't want to have.
I've been seeing a lot of patches coming to marketplace.
Mm-hmm. Yeah, patches is it's another delivery method. You know, there's a lot of medications, you know, that are applicable with patch. Clonidine, for example, for blood pressure. Fentanyl for chronic pain. So the cannabinoid is the same. You get pretty good delivery with the patch system. We get transdermal absorption gradually. What they've shown with topicals is that you know, there's good local absorption, minimal systemic absorption. Patches, because they're occlusive and often they'll have more nanoparticles and things, you can get a little more systemic absorption from the patch. So you'll have measurable serum levels of the cannabinoids when you're using a patch. And they're pretty long-lasting too, can last up to 48 hours.
One of the issues I see with patches is the compliance factor, where often patients are not happy with this thing stuck to them, or they sometimes may get some irritation to the skin, and so.
I would love to see a patch develop for children when they don't like the taste of the oils or, when their foods, and I just slap a patch on that back, they wouldn't know it was there.
Is Adam in here? No. Are we doing questions from the audience? No? Yeah, go ahead. Go ahead.
Is there any truth to the fact that some products are water soluble and some are not, and whether is it better than the others? The CBD in particular. Because some of the products that you ingest have to go through your gut to be processed and through your liver to go throughout your system, whether the water soluble or don't have to go through that process. Is that true or not?
I will tell you the cannabinoids are all lipophilic, so they do better in oil. And if a patient is going to ingest the cannabinoids and we want quick ingestion, we'll have them take something like oil products, so it absolutely increases absorption rate. So it's probably better in an oil.
It is oil, but
yeah.
it's water soluble. That's what they're marketed as.
Well,
Yeah,
yeah,
yeah.
what I see there may be partially,
85% absorption rate, which nobody can claim for that. That's
Yeah.
what they're marketing it as.
Yeah,
I
I'm
think
not
part of
sure
it is
I-
sometimes a homogenization factor. So if they do have a lower concentration oil in something, you don't want all that oil, like salad dressing, right? You don't want the oil in very high concentration one part, and yeah, exactly, right. So as far as I understand, the water soluble is a component that's making it more homogeneous throughout, and therefore delivering a more consistent dose through it. I'm not sure if it's affecting the actual absorption rate.
Yeah, their reasoning is that not 100% of the cannabinoids are used in the body because they go through the digestive system.
Yeah,
That's their reasoning. Is that correct?
Well, yes and no.
Yeah, I think that the big variability with ingestion is bioavailability. Is a fairly broad range. Studies have shown maybe only 6% absorption, 20% max. You get stomach acids breaking it down. What else you've eaten makes a big difference. If you got fatty foods in there, you may absorb it more than if you just got carbs. So a lot of variability. The big factor, of course, is first pass metabolism in the liver. And what we mean by that is that when anything you eat, the digestive tract, venous return goes through the liver first, through the portal system. Okay, because the liver's responsible for really metabolizing everything you eat. So all the cannabinoids are metabolized in the liver. If you inhale it or take it otherwise, it gradually goes through the liver with your circulation. But when you eat it, everything's going through the liver first. So that, causes a metabolic breakdown of those cannabinoids, before it even gets into the body systemically. So that's the big variability. Now, it's not too big of an issue with CBD. With THC it is, because the first metabolic byproduct of delta-9 THC is a side chain modification. Now it's 11-hydroxy-THC. When you measure blood levels after eating, the peak is about 5 times higher of 11-hydroxy-THC than other means of ingestion. 11-hydroxy also is about 5 times as psychoactive, much more affinity to those CB1 receptors. So that's where people get into trouble with the edible THC products, is your brain's 2 hours down the line getting hit with this flood of 11-hydroxy. Now you are couch lock stoned, Yeah. So CBD also has a real effect on the cytochrome P450 system in the liver, responsible for metabolism. You got to realize it's responsible for metabolizing 60% of your other pharmaceutical drugs. So that can have a big effect on you as well. So.
Okay, so add on to that question, if you take an oil orally, so it's faster in your bloodstream, correct?
Yes.
It's faster to your receptors as well, right?
Yes.
So then therefore, if you take it orally rather than like a gummy that goes in your gut first, then you have a faster and bigger absorption in your receptors, right?
Right, yeah, the studies have shown, kind of peak blood levels from mucosal application to be about 15 to 20 minutes. That compares to 5 to 10 peak serum levels for inhalation. Ingestion, it can be anywhere from, 45 minutes to 3 hours, so.
And we also talk about therapeutic blood levels when we're treating patients. So the highest is with nasal septum, and second is the suppository, which is surprising to a lot of people. Third is the sublingual or into the gums, and distant, but fourth, are the edibles, because of the first pass effect. So when we're treating different patients, depending on their disease, that's how we're going to recommend the route of administration for them. Just depends on what disease we're dealing with and where we need to get with that therapeutic blood level.
Add on to that, what illnesses do you use suppository for?
Cancer, anything in the pelvic area, prostate cancer, prostatitis, female organ problems, back pain, because they're right at the target organ. GI troubles, and particularly patients who can't eat or drink, then we'll give them suppository as well. And certainly the cannabis patients, particularly if we need THC, and we want to get a higher level without the side effects. So it really does depend on the disease process.
And I've read one article that said suppositories may help your ED as well.
First, thanks for a great panel. So I have a question that my father's in his 80s, and I recommended he research CBD. I didn't want to tell him what to do. Have there been any studies, or have you had experiences with your patients where there's interactions between, he's got a list of probably 10 or 15 drugs that he takes for his blood pressure, this,
Yes,
that.
yes.
Is there a concern that I should have for him about that?
Well, what we talk about, and Dr. David mentioned it, where the liver metabolizes most of those medications, and we're dealing with what's called the cytochrome P450 system that breaks down all of those drugs. So in a lot of elderly patients, you'll see on the drug labels where it says, beware of grapefruit when you're having your medications, where cannabis, CBD in particular, is even a stronger inhibitor or blocker of that cytochrome P450 system. So not only does the cytochrome system metabolize CBD, but it is a competitive agonist, so it'll shut it down. So we tell patients to be aware of that and make sure they get their blood levels, particularly if they're on something like Coumadin or warfarin. We need to watch those blood levels. Now, I personally have never seen anyone get into trouble with it, but it's one of those things we definitely have to make sure that they understand. So if you have a father on a list of medications, the doctor needs to understand he's taking CBD.
I guess just to expound on that, is that clinically, there's a lot of theoretical, worry about the interaction, but clinically we see very little of it. They've been some studies, there's a few medications, some seizure medications where the blood level has increased. Most of them are still within the therapeutic range, but just a few are above the therapeutic range. It can elevate liver function test too, give you a little hepatitis kind of a picture. But for the most part, on a clinical basis, it's not really proven to be a big concern.
What, if any, experience have you had with expectant mothers and CBD usage?
It's such an all-the-time question. And what I will tell you this.
Children and mothers,
From conception to death, that endocannabinoid system is working for you, and there's actually endocannabinoids in the mother's milk. Now, there certainly was a Jamaica study that talked about the lower, IQ with mothers who used, but that hasn't panned out to be the truth. So if I have a mother and she is in pain, I would much rather see her on CBD. I would sort of back down off the THC, but I'd much rather see her on CBD than taking one of the pain medicines like Demerol or anything else like that if she's pregnant. So I do not discourage pregnant mothers if I think they need that CBD for whatever they may need it for. But that's a loaded question.
I know, that's why I asked. Speaking from a personal sort of
Yeah,
perspective.
but I think it is interesting because, you know, just the number of patients I'm seeing. I'm seeing some pregnant patients, you know, and they're saying, oh, no, my midwife said, no, that's fine, you know, you go ahead and use it. And you know, so I think it's becoming a little more accepted, you know, that it's not the big risk that it's purported to be.
Thank you.
My question is, do you have experience in using other cannabinoid isolates besides CBD or THC or mixtures of isolates to have therapeutic results? For example, I've heard of mixing CBD with THCA to create a THC-free mixture that's really good at treating epilepsy.
And that's true. What we're finding out with science is that we can put certain cannabinoids together with certain terpenes and probably get pretty close to what THC can do. So it really is a matter of understanding the physiology and the receptor system. And the ECS is more than about CB1 and CB2. There's other receptors. And CBD is called the promiscuous cannabinoid because it works on all other kind of receptors as well. THC is very powerful when used to treat seizures, but also nausea, along with linalool. So we put different compounds together to get an effect.
My interpretation of this as well is it's sort of a regulatory thing as opposed to a clinical situation, right? There's this regulatory framework that allows more CBD application and CBD conferences, but I think ultimately as those barriers change, you're going to see cannabinoid therapy with a whole range of cannabinoids. Although part of it comes down to availability as well. You can get more CBD from a plant, you can get more THC from a plant than some of these rare cannabinoids.
Experience with CBN, CBC, something like that.
Absolutely. CBC, great. GI trouble, CBG as well. And you all know CBG is the precursor to all the cannabinoids. But yes, once again, it depends on the disease and how specific can we get when we understand how those cannabinoids work. CBN is great for sleep. It's probably better for sleep than even THC. So yes, we do tell patients, I have a patient now who's having insomnia problems, and we're working on getting CBN for him to add to his CBD and his THC.
Can you speak to how much dosage for CBN?
Dosage has been stated to be anywhere between 5 to 10 milligrams, but once again, you're talking about individualized medicine. It depends on the individual and the state that their ECS is in.
I work with a pain management clinic, one of the few that's actually steering away from opioid use, actually not prescribing as much anymore, working more towards an interdisciplinary functional restoration approach. We have a wide range of chronic pain syndromes, from failed lumbar to neuropathic complex regional pain syndrome. But the question I have is more towards what you said with transitioning from opioids to something else. We currently use Suboxone for morphine. And what would be your experience or thoughts on transitioning using something more like CBD? Would that supplement the buprenorphine, or would it possibly replace?
I generally try to tell patients first thing is we're going to try to get them off as many pharmaceuticals as we can. So it's a titration that we try to do and go very slowly to do that. And that's with all the opioids or any other medication. So as we're trying to come down off dosage of the pharmaceuticals, we're increasing the dosage of their cannabis as they can tolerate it. You know, and it really is still trial by error because it is an individualized medicine. Did you want to say something?
Yeah, I'd like to expound on it, particularly from the aspect of how pain clinics are managing, pain patients. Because there's a lot of work to be done in that area. I have to say, when I first started this, then what's got me most enthused about the whole, medical cannabis program, the number of patients, thousands of patients we've seen who get off or significantly reduce their use of the opiates. As I said before, cannabis is synergistic with the opiates, makes it more effective, doesn't develop the same tolerance. So these people are able to maintain on a very steady state long term rather than needing the increasing doses. A lot of people are able to get off the opiates. Of course, all the studies now are showing, long-term opiates really are not the proper treatment for chronic pain. And you have to agree with that. But there are some people who have enough pain problems, they may never get off the opiates completely. And it aggravates me no end the number of patients I see who have been kicked off their opiates because they test positive for THC. In my opinion, I've developed is that if you're on opiates, you should be on cannabis also. They should not be, prescribed separately. But, we've got a long ways to go with that politically. Anyway, but yeah, in the emergency room, we see chronic pain patients all the time. They've been cut off their opiates. Now they're in with an acute exacerbation of pain or even withdrawal. What are you going to do? I'd say the Kaiser system is kind of the biggest one that kicked their patients off the pain management. But, yeah. Right. Absolutely. Yeah. Now, Suboxone, buprenorphine, as a substitute for opiates, just like methadone, it basically just substitutes another drug for your opiate receptors. But I think the same principle applies. You put the cannabis along with it, it's synergistic. And, and the whole idea is that it allows you then to gradually taper down on doses of any of those things with the ultimate goal. Hopefully you're going to get them off it.
We have to wrap up, unfortunately, because, can we do one more, sir? Yeah.
Just one last question for anyone in the panel. What makes the product medicinal grade and not the other?
Who wants to tackle that?
I'll speak a little bit to that, we do have products on the market, so.
It's called nutritional supplement, that's what it's marketed as. Why would they call it medicinal?
Well, and the points I would make is that any product should clearly tell you what's in it. So concentration should be there, and a lot of products don't disclose concentration. And if they do, it might be a little bit misleading. They may talk about, they're not referring specifically to CBD concentration. They may be referring to the overall hemp oil concentration. So they're not being clear on what's exactly in there. So I think one of the things I say to consumers all the time is make sure you're really reading the label closely and make sure that it is disclosed what's in there.
And for
It's
us,
kind of a simple thing. It should apply everywhere, but in this emerging industry, it's not always clear in packaging.
And for us, it's the concentration per milliliter. It's always, weight per volume. And so if we have a patient who's coming in with, like 30 milliliters and the whole product has, 30 milligrams of cannabinoids in it versus maybe 650 milligrams per milliliter, we don't want a patient taking volume bottles of oil to get one dose in. So we're going to look for something that has a higher milligram concentrate per milliliter. And once again, we're looking at what does the label say? Is it giving us the ratio? What is the CBD to THC ratio or CBD? Is it telling us the volume content? Is it telling us the milligram content? Has it been tested? And how is it labeled? We want to know everything about that product before we even begin to recommend patients take it medicinally.